So I'm going to start, and you can see that a lot of things I'm going to talk about along the way. And I'm going to start. There's a reason why I didn't share this talk with Rena, my wife, because she would have put her foot down and said no. And but to acknowledge Rena's role in all of the things that I've managed to do, and a lack of a role in all of my mistakes, and there are plenty of them, and just to say it again. And so you can also see Ainsley in our picture. And Ainsley is a very big part of our life, and I can see Sonia on Skype who's smiling. Johnny and Zanny, you can see that Zanny manages to have a rat with her. It's a beautiful rat, and I don't know the name of this one. And then Sonia, who it's a picture of Sonia at the Chinese bridge. She's now bridge that and is in China. You can see there are lots of animals, and I do remember Nico's talk and his beautiful cat called Skilly, and I can't compete, but in terms of beauty, but in terms of weight, possibly yes. So I want to start off with my parents. They were very young, and I think they were probably not married yet. And to acknowledge their roles and their influence, my decision to do medicine, or the calling of medicine, came from my father. He was a pharmacist, as you've heard. He would have loved to have done medicine. He couldn't. The family was very poor, and his maths was appalling. And in those days, extra lessons didn't exist, and it just wasn't an option. He did pharmacy, and he enjoyed it, and he mostly enjoyed talking to people. My mother taught us lots of things: a love of reading, a love of art, theatre, and seeing the other side, and looking for people who were maybe not as privileged as we were. You've heard about Cotton's Old Pharmacy, and my father started in 1947 and really enjoyed it. And 52 years later, he closed the door and went across the road to his opposition, Monument Pharmacy, and he was very happy there as well. So when one thinks about early influences, I have memories of the Goodwood Primary School, and that is our inter-school team. I was in the under-9 group, and in the background you can see Mr. Koos Sadi, the headmaster, who, to quote Dr. Sapperson, is a gifted educator. And what he told us, and I remember him standing on the podium saying, "Julle moet skryf wanneer julle leer." You must write when you learn. And what I actually learned from that is that learning is an active process. Whether it's at school, you're learning facts and concepts, and later on you've got data and ideas, but when you're active with what you're dealing with, you get a handle on it. So I graduated in 1979, and that was a proud moment for all of us. I want to acknowledge some of the family practitioners in Goodwood. Dr. Gerald Bureau, a great influence in my life, esteemed in his community, sorting out clinical issues, really doing intellectually stimulating work, and Dr. Jaime Ehrlich and his daughter Michelle is with us, and he's in Israel, by the way. He's in good shape, and Michelle's husband Sam, and then Dr. Dave Sapperson, and he graduated in 1955 at Wits, and the proudest moment in his life was when his grandson Larry graduated in 2011, and Larry has been able to come tonight. So now I want to go into some research, and I thought clinical trials are a lot of what I do, and why not talk about the first trial that I did. And this was called Methylphenidate versus placebo. And for those who don't know, placebo looks like an active drug, but it's not. So you're not quite sure what you're taking. And methylphenidate, or Ritalin, is used for children who have problems concentrating. And we did what's called a randomized, double-blind crossover study in children with the attention deficit disorder, which maybe was not the right title, and you can see that neither the teachers, the parents, or ourselves knew what the patients were taking, and we scored attention span using something called a Conners chart. Now, in those days, I thought I knew what was going on, and I designed a score sheet without piloting it, and I was really convinced that this was the way to go. And luckily, Dr. Jennifer Cartwright, who's now affiliated to our Department of Paediatrics and Child Health at Stellenbosch University, was a consultant at Wits. And she said to me, I think you'd better use the Conners chart, which is what we did, and that's why we actually had some findings. What we found, though, was that the children did worse on Ritalin than on placebo, and my current interpretation is that the selection of patients was probably wrong. They shouldn't have been on it in the first place. So now, behind the paper and the science is Rena, and at that stage we were living in Johannesburg. I was at Wits. Rena was at Onderstepoort. We had 2 children already, and we did this work at the New Hope School in Pretoria. The reason that we did it there was because when I was in the army, I worked in a learning disability clinic in the Army. This was started by Professor Andre Venter, who still does learning disabilities at the Free State University, and then Professor Andrew Argent. I bet he's an intensivist at Red Cross, and I bet people don't know that he actually knows a lot about learning disabilities. But you can see that this trial worked because of Rena. And so I really now want to acknowledge your help. Thank you. And I didn't at the time, which was a big mistake. So while at Wits, in fact, what I should first say is that learning disabilities are very challenging, and I can confidently say I had no idea what was going on. And when you read literature from the UK and Europe, and you read literature from the United States, it was totally different, probably about different children as well, and it was much too abstract, and I really needed something concrete. And what happened was that Dr. Frank Berkowitz had just arrived back from a 2-year fellowship at the University of Health Sciences in Colorado as South Africa's first pediatric infectious diseases specialist. And I learned a lot from him. I was inspired by his clinical acumen, his caring, his science. and his approach. And also using what he was doing every day for his research. So this was my first paper, and was working in the intensive care unit at Coronation, and a little premature baby developed inflammation on the hand from a drip site. And Frank said, well, we better aspirate and do a gram stain, which we did, and we saw candida or yeast, and we obviously treated the child. We knew exactly what it was, and we wrote this paper. It turned out that this complication, or hospital-acquired complication, had never been described in a premature infant. So using some curiosity and with a good mentor, one can go a long way. Coming to Tygerberg, our reason for coming back to the Western Cape was that my mother-in-law, Rena's mother, was in remission from ovarian cancer, and we needed to come back. I could have gone to Red Cross as a community pediatrics registrar, but Professor Peter Donald was at Tygerberg, and it was a very strong motivation to come here. And we did studies in tuberculous meningitis, and I've listed 2 papers that also with Professor Johan Skuman, and that were quite interesting. So what we did was we looked at something called the syndrome of inappropriate antidiuretic hormone secretion in TB meningitis. And what happens is this is a vasoactive peptide. It makes you retain water, so your salt levels become very low, so low that it can be very dangerous and even life-threatening. We actually developed a hypothesis based on measuring intracranial pressure, which is increased in TB meningitis, and blood pressure as well, and we measured antidiuretic hormone levels. And what we found on finding a direct correlation with antidiuretic hormone levels and blood pressure, we hypothesized that the reason that this hormone is secreted is to raise blood pressure to allow the brain to be perfused. One of the things we do as doctors, we give lots of IV fluid with low sodium levels, so we think we did some harm. And this unmasked the very dangerous sodium level. So now I want to go to HIV, which has been an all-consuming challenge and tragedy that I have been very privileged to work in. The start of this condition was a publication, a case series in 1981 put out by the Centers for Diseases Control in Atlanta, Georgia. And they described 5 young men. They were all homosexuals, and they were treated for a condition called pneumocystis pneumonia. Now, this condition was known in very, very immunocompromised patients and was very uncommon. And they had another virus infection as well. They had candida in the mouth. They were very immunosuppressed. It was very, very unusual. And interestingly, a drug technician at the CDC who counted the requests for the treatment for this rare condition, and she realized something was wrong and alerted her colleagues. So now in academia, the core of academia is a peer-reviewed article. The CDC publication is not peer-reviewed, and the first peer-reviewed article was published 3 or 4 months later. And that was of a condition called Kaposi sarcoma. It's a kind of skin cancer, and again in homosexual men from New York City. And you can see what it looks like, but they called it something else. They called it gay-related immunodeficiency, And like in many other spheres, we have an acronym. They called it GRID. And that's actually how this started. You can see again that in the United States, it was extremely rare. In Uganda, interestingly, in 1962, it was incredibly common. So surely something was happening. The term AIDS came from Dr. Bruce Voller, and you can see an arrow pointing to him, an activist and a scientist. He was the founder of the National Gay Task Force. He objected to the term GRID, and he suggested the term acquired immunodeficiency syndrome as being something more accurate. So even in those days, AIDS was steeped in controversy. And the next year, it was accepted by the CDC that AIDS would be the term to describe this condition. I'm not going to read some of the research that he did, but you might think that this is a bit weird, but in fact, it is highly appropriate to look at human sexuality in a very scientific way and produce the best data that you can to help people. So the first report in children came the next year, and you can see the pace of developments. Basically, what happened was that 4 infants were born to women who had risk factors for HIV, well, at that stage it was AIDS, drug use, and prostitution. And their children, their babies, were extremely sick, and this was extremely uncommon. So at this stage, no one knew what the cause was of AIDS, but it was obvious that it was a transmissible agent, that there were risk factors, and that it could be transmitted vertically or from mother to a baby. So this is what happened in children. The discovery of HIV came a year later, and you can see the Nobel Prize winner is Francis Barré-Sinoussi. So this was in 1983, and the next year the main target for this virus was found, and that was what's called the CD4 antigen, which is an essential component of our immune system for the T helper cells. This is one of our lymphocyte classes, and that happened the next year. So the next step, because to find the virus is difficult, you need an antibody test. And the antibody test came in 1984, which is really a year later. And you can see already when they tested various populations for presence of antibodies to HIV, you could see that if you had AIDS, you had 97% of the group had these antibodies, partners 42%, asymptomatic homosexual men 17%, and then hemophilia patients 34%. So this was how things started. And what about babies? Now, the first point is that an antibody always crosses the placenta into the fetus, but the virus doesn't. It can, but it doesn't. So if you find the antibody in the baby, it's a marker more for the mother than the baby. So how would you know if the baby has HIV? So let's go to this man. This is Kary Mullis. He described the polymerase chain reaction in 1987. He got the Nobel Prize in 1993. And what this is, it's the amplification of DNA or RNA from an organism. In this case, it was HIV, and it amplifies it so much, and each organism has its unique signals that you can actually make a diagnosis with confidence. And that's how it happened. In the same year, you can see that already this technique was used to identify HIV in patients, and 3 years later, a landmark study in Africa showing that this could be used for diagnosing HIV in babies. Now, today, this has industrialized, and we do round about probably 300,000 PCR tests per year, or approximately, in the country. So this is industrialized, and this is where it all started. You can see that HIV can cross the placenta, it can enter the baby during birth, it can cross through the breast milk. Feeding pre-chewed food to weaning infants can transmit HIV, and so can poor infection control. So the one question is, when does it cross? And it's been shown from fetuses as young as 9 weeks. And this picture over here shows HIV in the brain of a 16-week fetus. And remember, pregnancy lasts for 38 to 42 weeks. So it can really cross. It can get to places that we don't want it to get to. So the earliest known HIV was then in 1959 from a plasma sample from an adult male, and you can see that over time, complex, challenging patients who doctors remembered, when tests became available, they could look back at stored samples and track what HIV was doing and how it was spreading. And you can see in that picture just exactly how it spread in Africa, starting centrally and really a heavy burden in southern Africa. So now I'm going to tell you about Denver, United States, where I went for the fellowship and where Sonia was born. And you can see us at Aspen at a pediatric infectious diseases seminar, the most beautiful place. A truly remarkable faculty of really, really good clinicians and good scientists to manage the interface of science in the laboratory and the patient. And I'll mention them: Mimi Glade, who's some of my colleagues know, who've been to Denver, Jim Todd, who described the toxic shock syndrome for the first time, Myron Levin, Mark Abzug, and John Ogle. So now to my research over there, and a new form of cell death had been identified called apoptosis, or physiological cell death. And it came from the observation that in the autumn or the fall, leaves fall off trees, off annual trees, and that happens for the good of the tree to survive the winter and to carry on in another cycle the following spring. So I worked in Terry Finkel's laboratory. She and a colleague, Nirmal Banda, had just described how HIV might cause disease. What they found was that the outer coat of the virus and a little part called GP120 could attach to lymphocytes, CD4 lymphocytes, that did not have HIV. And it could cause them to die by this mechanism of apoptosis. So for the first time, and this was in 1992, a possible explanation for how HIV caused disease came, and it led to this paper that I'm showing you, which looks at the lymph nodes of patients. And what you see is that the green represents HIV being produced by cells, and that's messenger RNA. The red are cells that have died, and they have died by apoptosis, and that's why they're red. So when you look at the number of cells with HIV that are producing HIV and the number of cells without HIV but are dying, you can see a good correlation, and suggesting that this is going on, and maybe this is still relevant to HIV pathogenesis. if one could figure out why the uninfected cells were dying, it might lead to different forms of treatment. And you can see Dr. Finkel hard at work in the laboratory over there. So we came back to Cape Town, and things took a funny turn. And this is really what happened. So this headline appeared in the Cape Times in 1996. 16 babies die in a city hospital. What had happened was we were, when I was back and establishing an infectious diseases service, there were lots of cockroaches in the wards, and they were running all over the babies. And, I'd written a letter to the head of the hospital saying this is really bad, and these babies are going to get sick, and we should do something about it. So when the neonatologists saw this rise in their statistics, at the same time, somebody leaked this letter to the press, and I don't know who it was, although I have my suspicions. And most of these babies had a terrible condition called necrotizing enterocolitis. They all had, they were septicemic, they had bacteria in the blood, and it was highly resistant to antibiotics. This is what it looks like. It's terrible. The air gets into the lining of the gastrointestinal tract, and these infants very often die. So here are the cockroaches, and we collected them, and we put them on agar, and we could show this resistant organism that was growing. And when Tygerberg Hospital was built in 1976, vinyl was put on the walls, and 20 years later it was starting to peel off, which was very good for the cockroaches, but not good for anyone else. So they were immune to efforts to eradicate them. So what do we do? It's very, very difficult. We tried to implement infection control. We got a team together, and we also collected isolates from the baby's blood, from the cockroaches, and also the same germ that was colonizing the gastrointestinal tracts. A colleague of mine from Denver, Mary Ann de Groot, and you can see over there in 2013, many years later, and at that stage, emails had just come in, and I asked her, well, what should we do? She said, well, why don't you do pulsed field gel electrophoresis, which I'd never heard of, but a very young registrar training in microbiology, Dr. Elizabeth Wasserman, who subsequently became head of department, put all the isolates in a suitcase and flew off to Denver and did this assay and showed that the cockroach organisms were identical to those that were harming these babies. And it led to a publication, and in a tragic way, that the loss of these babies had been a stimulus for this type of science, but you need data in order to make any changes, and we had the data. And you can see our team. We had a celebration when we'd eradicated this problem, and the cockroaches, in fact. So back at Tygerberg, things were very different. There was a huge clinical load. The resources weren't good. People were a bit depressed. These children were coming in, they were dying, and they were sick, and what could we do? So the first thing to do is to count, and that's what we did. And with some elective students from Holland and Professor Scarf, we actually counted, and we, not health economists, but we got an approximation of what it costs to have a baby sick in hospital, and could show that for what was then a preventable condition, we were spending a lot of money on treating children in whom HIV transmission could have actually been prevented. So where that started was the idea of triple therapy, combining 3 antiretrovirals together. And in 1996 in Vancouver, the first scientific news came out that if you used 3 antiretrovirals, especially if from 2 different classes, you could eliminate the virus from blood. And that was quite amazing. Looking at children, when there was no antiretrovirals, when you used 1 or when you used 2 and when you used 3, you could see that there was a big effect. And this was looking at death of children. And that was published in 2000. So we really needed to get triple therapy. So shortly after my arrival at Tygerberg, we saw a patient that we cared for. This little child came in with airways obstruction, struggling to breathe. It was upper airway obstruction, and we really didn't know what to do. And we found that the adenoids and the tonsils were big. We had them removed by Professor Luc, and the child did better, but then about 4 days later came back in severe heart failure and unable to breathe. There was only one thing to do to save this child. We had to do a tracheostomy, and that's when you make a hole in the airway to allow the child to breathe. The personnel in the ICU were very worried about infection control, and there could be blood. We already knew that blood could be dangerous, and they really didn't want to accept this child, and one couldn't blame them. Then we had an idea. And we said, well, what if we give an antiretroviral to the baby, then the blood will not be infectious and you're going to be fine. And they accepted that explanation. I'm not sure if it was true, but they did accept it. And the baby was started on a single drug called AZT or zidovudine and made a miraculous recovery. So much so that the procedure wasn't necessary anymore. The patient went home. We followed him up about 2 months later, and it was amazing. So we really thought, well, we're never going to get triple therapy. It's too expensive. No one can afford it. Maybe we can use monotherapy in a different way. Another point that I want to make about this patient is that we had some stored serum, and because I'd been to Denver, Colorado, I thought, well, why would this child get such big tonsils and adenoids? And we tested for Epstein-Barr virus that causes glandular fever or mononucleosis, and it was positive. So we began using monotherapy. And we actually, when the whole world was using triple therapy, we were using monotherapy, and we actually showed that we could reduce hospitalization of very, very sick children just using a single drug. And it wasn't what we wanted, but at least we got them home to their families. What was going on with HIV? Well, there was an anonymous survey for HIV using the antibody test that started in 1990 and continued every year so one could track what was happening in pregnancy. And you can see what happened, that absolutely logarithmic increase from 1990 through to around about 2003, and then things stabilized. When you look at the interventions that were available, the first study showing that you could reduce transmission was published in 1994. It was a bit complicated, and 4 years later, a much simpler way of doing it was described and shown to be successful, and the complicated part was giving zidovudine intravenously during labor. And over here, they showed you could give it orally, and it was fine. The next important step was in 2000, when, 1996, when a single dose of a single drug could have dramatic influence. Looking at what happened in South Africa, you can see that terrible delay, and only in really 2001, 2002, there were a couple of pilot sites, and eventually 2003, 2004, it improved a bit. The delay was tragic. We started our own program at Tygerberg before it was easily available, and you can see the person who did it, Dr. Elena Rabi, and what we did was using postnatal AZT or zidovudine to babies in whom we knew their mothers had HIV to try to prevent the transmission. The reason we could do this is because a study had been published showing that this was possible if the mothers missed it in pregnancy, and it had a good effect. So in 1998, we weren't testing anybody, but if the women were sick, they would have an HIV test. If a doctor or nurse had a needle stick injury, they would get an HIV test. And what was not available was screening and counseling for everyone, preventing this pneumocystis that I'd mentioned, and all these other things that are important in counseling and preparing young women and young families for their children who are coming. What we think happened in our small series was that we probably prevented some infections. We showed that it was possible to do this, and we also showed that if you're not trained to do this, and if your team aren't trained, you make lots of errors. And so we were learning. 2000 was a pivotal event for HIV in South Africa. It was the 13th AIDS conference in Durban, and for the first time, HIV and treatment got onto the international agenda, all focused in Cape Town, in Durban. And people were asking, why are these medicines not available? Why are they so expensive? Why can't we get them? And you can see that it was tragic, and people were very angry, and there was not good response from the political leaders of the time. And what happened was that things changed afterwards, and lots of things happened more or less at the same time. So what I've shown you is how we started, and we started with triple therapy in 1999 through a pharmaceutical study, gradually as more of these studies became available, we could treat more children through HOPE, and through other studies we were able to treat some, but then the rollout started, and we were well set up to start 300 children on HIV, on antiretrovirals very, very quickly. So the children were incredibly resilient, and this patient who was treated through one of these projects was on lots of drugs. You can see all of them there. He did pretty well. And so when we look at what was then, and we look at the age group of our patients in 2004 to 2006, we can see that most of them were very, very young. And when we compare to now in 2015 in the red, you can see there are not many young patients there. They're all getting older, and they're becoming adolescents. And there's been a total shift in what we're seeing. So we've managed collectively with colleagues throughout the country and the continent, we've managed to pull a lot of children through, and they're growing up. So because of all of this, we managed to establish the Children's Infectious Diseases Clinical Research Unit that we call KidCrew, and we must have known that neurocognitive studies and dyslexia would be an important component of what we do. We've had our 10th anniversary 2 years ago. The idea was to improve the health of children and their families through research into infectious diseases. We, through some of these international consortia, the Impact Network, we conducted some very important studies, finding out which antiretrovirals are better. Is it A or is it B? We did studies on how to prevent HIV in babies whose mothers didn't receive any antenatal care, in a very big collaborative study where Professor Gerard Teron led our team. We could all show that using 2 or 3 drugs were better than using 1 drug. So these have been very, very important studies. And I now want to talk about the first randomized controlled trial in KidCrew, and this was done with Professor Heather Czar from Red Cross Children's Hospital. And the background to this was that the Rockefeller Foundation were sponsoring a conference on how to manage HIV in Africa. This was in 2001, and this was really part of the notice after the Durban AIDS conference that Africa was getting. So donors were starting to collectively make lots of plans. As a result of attending this conference where we had to, or where we presented data on immunization and on prevention, we developed this trial. And it was, this data was released in 2006. What we did was we had compared isoniazid to placebo, and we found that quite dramatically, soon after starting the study, there was an immediate difference in mortality. You can see the survival effect in the children on isoniazid. That's a medicine used to prevent tuberculosis. And this trial was actually stopped because of this because of this finding, and we were asked to make this data public. This was the design of the trial, and in fact my idea was to compare daily trimethoprim sulfur, and that's a medicine used to prevent pneumocystis and other bacterial infections. I thought it would be good to compare it to daily to 3 times a week, and Heather thought we should be looking at isoniazid to see if we could rather prevent TB. So we combined the 2 ideas and did what's called a factorial design study. So through the Impact Network, this study was done a little bit later, and it's another study looking at isoniazid to prevent tuberculosis in HIV-exposed children, and is a cautionary that you really need to know what's going on in your environment. We were convinced that this would work and wasn't even worth studying. And in fact, what happened is it didn't work, and we really struggled to explain that. So what we showed with Heather is that the patients on isoniazid had not a lot of TB. Those on the placebo had a lot of TB. When we looked in a slightly different setting, and these were babies before they got exposed to TBs, they were between 3 and 4 months of age, there wasn't a big difference. There was very, very small difference, and it was not statistically significant. How could that be? So, when we looked at access to antiretrovirals in the earlier study with Heather Czar between 2002 and 2004, before these medicines were available, you could see that not many children were on antiretrovirals at the beginning, and not many were on antiretrovirals at the end. with the advance and availability of antiretrovirals, more on antiretrovirals at the beginning in the IMPACT study, and by the end of the study, all of them were on antiretrovirals. When we looked at how common TB was, you can see that for those who were not taking any prevention with the study with Heather, TB was very, very common. But overall, in the next study, when antiretrovirals were available, it was far less common. So maybe isoniazid isn't the greatest drug to prevent TB, and a lot more work needs to be done. So I think that was a very cautionary tale. So what about early infant diagnosis in 2004? So at that stage, the guidelines in the Department of Health were that if the baby's sick, if the mother's sick, look for antibodies, and they could have HIV. And at that stage, the PCR was not really available, but it could be used if it was available. Already, work by Di Gibb and her colleagues showed that the younger you were, the higher the risk of death. We were all looking at CD4 counts and using that to gauge what kind of risk you are at. The antiretroviral guidelines were very complicated, and you can see there are lots of conditions. They've got to have a certain level of sickness, a certain level of CD4 count, and if you can't measure the CD4 count, the other alternatives, and then you treat. And that's really what we were doing. So now I'm going to the SURE study, the Children with HIV Early Antiretroviral Study, and you can see some of the investigators, Di Gibb, Helen Payne, Avi Violari, and Ab Babaker. This was recently in 2015 where this was taken, but we began planning in 2001. There were no antiretrovirals, there was no early infant diagnosis. We started out with the need to treat infants and the possibility of intermittent antiretroviral therapy, and with the contribution of Di and Ab and ourselves, but really the trial design and the statistics from Ab and Di, we undertook the SURE study. So what the idea was that if you were to diagnose HIV early and get these infants over infancy, where we could see with our eyes if they were vulnerable, we might be able to delay disease progression. At that stage, we were thinking, well, these medicines are expensive, it's hard to give, maybe they're toxic, let's just give them, stop and watch very carefully. And this was the design of the study. So already we knew that a low CD4 was a bad thing and you got to treat, and we randomized patients or infants with a high CD4 into the standard of care, which was wait and watch, but it was really very intensive waiting and watching, and then 2 early treatment arms. They would just be treated immediately, one group till the first birthday, the next to the second birthday, and we would then stop treatment and we would restart when it was needed. And follow-up was for a long time. The children started at around about 7 weeks of age. So we were treating babies from 7 weeks of age. And at that stage, they had tons of virus in the body. So already when we looked at who were the children who were trying to enroll in this trial, we could see that under the age of 7 weeks, many of them, round about a fifth of them, already had severe disease, showing us that the pace of this infection in young infants was very, very, very fast. The first part of the study was just comparing early to deferred therapy, and we had what's called a data safety monitoring board who were looking at our data and told us in June 2007, where this trial had been going for 2 years, in fact under 2 years, that all children need to go on to early therapy. There was a big difference in death. So this was a study that was measured in death. Early treatment was much better than deferred treatment. And we also looked at how antiretrovirals affect the brain, and with Barbara Lawton could show that early therapy was very good for the brain of these young infants. Again, looking at HIV prevalence at the time, just before the study was started, you could see it was increasing. And as it was increasing, we noted that, in fact, the risk of death was between 1 and 4 months of age. Now, we didn't look under a month of age because we didn't have the data. This work was done by David Bourne, a public health specialist at University of Cape Town, who passed before his time, before he'd really could do many of the ideas that he had. But each year that HIV was increasing, so the death rate in young infants was increasing until it peaked in 2002. This work was published in 2009, which was 2 years after the SURE results came out. So these things take time, and there's a haphazard progression of understanding of these conditions, especially HIV. The full results were published in 2013, and what we could show is that even after following these infants for 6 years, the early treatment was really what made the difference. And right as far back as 2007 or 2008, when our data was released, the United States adopted the guidelines in 2008, and the World Health Organization in the same year. South Africa followed 2 years later, and we were very pleased and relieved when that happened. So this has had a major impact. What we could also show is that you could actually, once you got the infants over the first year of life, you could actually stop and restart. But without any major harm to our knowledge, but this was not strong enough to go into guidelines, but the early treatment stayed. This information I'm going to talk about later, this idea of stopping antiretrovirals, and you will see how the ideas about HIV has changed, where knowledge of being able to stop antiretrovirals in children could be very important, because it's not something that one could do lightly. So we also showed that if you had treatment for 2 years, it was better than for 1 year. Our sample size wasn't big enough to really show that definitively, so this was a trend. What about real life? When we looked at the children after the publication of these early results at the PHRU with Avi Biolari and in Cape Town, and you can see that Steve Innes led the study, and we asked the question, well, what was the shape? How good were these kids that were starting antiretrovirals under 12 weeks of age? The answer was terrible. Most of them had advanced disease. So programmatic issues and working with ARV clinics and colleagues is very important. And that is where groups like South to South come in, making the evidence work. So HIV, I've already mentioned that when triple therapy came along, you could remove HIV from the blood, but it stays in the tissues. Now, work has been done in adults asking how long would it stay in tissues if it's not in the blood, And the answer is around about 60 years. So it's not going to work if one wants to get rid of the virus. So we have looked in the SURE study, and we've looked at children on antiretroviral therapy for 7 years, and this was Gert van Zyl. We divided the children into those treated from under 2 months to those treated from over 2 months. And these were children in the trial who never stopped antiretrovirals. And there were some reasons for that, because they had showed some evidence that they needed to be on continuous therapy. So what we showed was that there was much less in HIV DNA and much less RNA in the blood cells of these children. But there was some. And when you have RNA, you have what's called productive infection, so there's a danger of virus being made and still being able to infect. So this is one of the first steps for a cure, and one of the first steps for possibly removing HIV from the body is at least to start measuring it. We don't really know if this is going to work or not. So another issue with antiretrovirals, and this work was done by Helen Payne in the SURE sample. Everyone wants HIV to be removed from their babies. And what you can do is you can do an antibody test that gives you some evidence of that maybe HIV isn't there. And what Helen showed is that when babies were treated between 0 and 12 weeks of age, and when you looked for HIV antibodies, they'd gone. But when you looked deeper and you looked at the cells, HIV was there. So many false hopes could arise from not using these tests properly, and for healthcare workers and parents not understanding where all these tests fit in. So we thought we'd really made a huge difference by finding that early treatment, regardless of CD4 or amount of virus, was the way to go. And it seemed pretty good, but then the report of the Mississippi baby was released in 2013, and this was a baby who had a very high risk for HIV. The mother was diagnosed with HIV when she was in labor, and so she missed any chance to prevent it. And the doctors decided that there was a high likelihood that the baby was infected. They started treating from the second day of life. The mom became a bit fatigued with all of this treatment and decided to stop treatment about a year later, and was lost to follow up. 6 months later, the baby was tracked down and they couldn't find HIV in the baby. So it looked very interesting. What if you treated really early? We thought 7 weeks was pretty good, but what if you treated immediately? Or what if you prevented very strongly in a way that you could treat at the same time? Maybe we could cure HIV in those babies unlucky enough to get it. And we were wrong. So the baby was followed for almost 2 years and the virus came back. What this blue shows over here is that it was the identical virus that was there in the beginning and the identical virus to what the mother had. So it's a possibility, but highly unlikely to happen. When cure therapy starts, and should interruption of antiretrovirals take place, we have shown in the SURE trial that it could actually be done, as far as we know now, reasonably safely. And that might be the final test of being able to cure when that should happen. So I want to thank all of my colleagues in Kid Crew, which has now become Fam Crew, because we now have an adult component. And you can see the colleagues over here, and there are doctors, drivers, nurses, finance, cleaners. Every single person is important. If they don't do their work to a very high professional level, our work won't work. It won't succeed. So I really thank and pay tribute to their professionalism. The adult ID team has just joined us, and we are thrilled to be able to work with adults as well. In Kid Crew, we have done lots of studies in the past, and we still are doing quite a few. And you can see the large number of patients that have been screened and treated. And even screening a patient for a study means you're uncovering issues that we try to resolve. This is the pediatric ID team who run our clinical service, and we are extremely grateful to this group, who are led by Helena. I've mentioned the South to South Center for Comprehensive Family Care, who go out there and make it happen, work with people at the forefront of treating patients. Where are we with HIV? And I thank Andrew Levine for this thought from Mishne Ovot, which says it's not for you to complete the task, but neither can you ignore it. So we've come a long way. There's a long way to go, and there are many people who have a role to play. I thought I would end with something about cockroaches from my brother, Roy, who passed in 1985, and with the idea that even thinking about a cockroach has meaning. And he said, a cockroach meditating upon the nature of things does not come to a definite conclusion. Why apples shrivel in baskets, why tufts of hair smolder in the sun, why the lawn injects strange vitamins into the earth. All these things puzzle the cockroach, who has no way of perceiving the blight of human aspiration, the seasonal ice peaks of the soul. And so I want to thank everyone again. I want to thank Una for her work, and Beira for helping with a prepared speech, and then also acknowledge Ed Handelsman, our medical officer. He was the head of the pediatric division of the National Institute of Child Health and of the National Institute of Allergy and Infectious Diseases, the pediatric branch, and behind the scenes supported the SHARE trial and allowed it to come to a successful conclusion. And then my colleagues, and thank you everyone for being here tonight. Thank you.